Morning, everyone. Um, Presenting on behalf of Medicine One, thanks, 5. So, it's regarding one 50-year-old lady who came to us with complaints of fever, headache, and not ambulating for the past 1 week, and also had vomiting for the past 1 day. So, for the history, she had come with a headache which was insidious in onset, gradually progressive, worsening, and she had a associated neck pain also. She had high-grade fever spikes, which are intermittent with chills and myalgia. She had loss of appetite, reduced speech, and gradually started having lower limb weakness. She became drowsy, but yet she was arousable, and she became gradually bedbound in a week. Also, she was noted to have intermittent altered sensorium in the form of not verbalizing and not recognizing relatives. But it was a very important process what they were telling. So she had no weight loss or no sweats, night sweats, no burning, micturition, rashes, or abdominal pain. There's no history of cough or hemoptysis, expectoration, no pleuritic chest pain. For this, like the patient also later developed a urinary retention and was catheterized also. So past history, there was no past history of similar illnesses. There was no exposure to TB. Personal history was normal. And for the examination, when she came to us, she was drowsy, yet she was arousable. She was oriented to time, place, and person. She was verbalizing on call. Vitals were all stable except for the pulse rate of 120. The JP was not elevated. There was no pallor sinus clubbing or lymphadenopathy. Systemic examination, apart from the CNS, everything was normal. So CVS, RS, and per abdomen was all normal. So the CNS examination, patient was drowsy but arousable. Her GCS was 15. Her cranial nerve examination, she had a right anisocoria. Her right side, her pupils were not dilated and fixed, and she almost had a frozen globe. She had ptosis. She had third, fourth, and fifth and sixth nerve palsies on the right side. Left side, there was abduction restrictions. Only sixth nerve was affected. Apart from that, the seventh nerve was not affected. Eighth was not assessed. Ninth and tenth, her gag reflex was absent. So, fundus examination showed papilledema. Otherwise, on the CNS examination, her motor bulk was bilaterally symmetric. Her tone was normal. For the powers, upper limb was 5/5, but she had a lower limb right from the hip flexion and extension, abduction, adduction. It was completely 0/5 when she presented to us. So it was bilaterally symmetrical. For the reflexes on the right and left upper limbs are all 2+. Lower limbs, the knee jerk was absent bilaterally. So the plantars were bilateral extensors. And for the sensation, for the pain and temperature was absent in both the upper limbs, which was preserved in both the lower limbs and below. And for the vibration and proprioception was intact in all 4 limbs. Cerebellar signs could not be assessed because she already had a frozen globe and she was not able to follow. And meningeal signs, she had neck rigidity. So here, there's a patient who has come to us with a subacute history of fever, altered sensorium, on and off altered sensorium with features of raised ICP and multiple cranial nerve palsies when she came to us with bladder involvement and loss of pain and temperature in the bilateral upper limb. So clinical localization, because she has come with the multiple cranial nerve palsies and neck stiffness and all, first one thing will be the meninges and the cranial nerves and the brain parenchyma. Second, she also had a paraparesis with a bladder involvement. So probably spinal cord, we can localize it. The thing is, so this patient had come to us with a history of paraparesis, and she also had a dissociative sensory loss. So one thing is, if at all she has this bilateral lower limb weakness secondary. So the one thing is it's a subacute meningoencephalitis picture who has come with the multiple cranial nerve palsies. So the first thing is we'll all consider will be a TB meningitis with the arachnoiditis probably. So if at all we are considering TB meningitis with an arachnoiditis, and then TB meningitis, as you know, it causes a extradural. It causes an extradural extramedullary lesion. So it is usually a vertebral, like an abscess or a pod spine. So in that case, the patient should have had a gibbous deformity or a radicular pain that is extending downwards, or the patient should have had a local tenderness on examination. None of these are present. Even if it is going to be an intradural extramedullary tumor, like if it is outside the medulla, just present around the arachnoid layer, still the presentation will be the same, except for there will be no local tenderness. If the patient had an intramedullary lesion, again, there will be no radicular pain. The first will be involved will be the bladder. The bladder layers will be the first affected, followed by the spinothalamic tract. So in this case, the patient can have a funicular pain, or the patient can have a dissociative sensory loss. So when this is first affected, so one thing is the patient has come with a paraparesis. Also, the patient is also having a dissociative sensory loss. So we were not sure if it is a arachnoiditis that is just causing the lower limb weakness, or if there is a syrinx involved. So if the syrinx is involved, then TB is highly unlikely, because TB usually presents as an extradural extramedullary lesion. Very rarely TB causes a syrinx. So TB meningitis with the pot sprain was considered. Other differentials we consider like neurosyphilis, neurobesets, neurosarcoid, vasculitis, or malignancies with metastasis. So these are the initial investigations, except for a very low, mildly low albumin, everything else is normal. We did a CSF counts also. CSF showed a lymphocytic pleocytosis. So after that, we entered the brain imaging. It showed a diffuse enhancement. Like basically, it showed features of tubercular meningitis because she had hydrocephalus, she had infective vasculitis also, she had endarteritis also, and there was basal exudates also. Second, her MRI spine showed a long segment anterior cord edema extending from the C5 to T2 vertebral segment, suggestive of an evolving syrinx. So basically, the MRI brain was suggestive of a TB, and the MRI spine was suggestive of a syrinx also. So syrinx with TB meningitis. So syrinx with TB meningitis is actually very, very rare because syrinx, if you are looking at syrinx, it's either a medulloblastoma or like a ependymoma or it's a syringomyelia. That is how usually the presentation is. TB, usually we have seen arachnoiditis, we have seen pot spine that is causing a gibbous deformity, but TB that is causing a syrinx is very, very rare. And the interval between the tuberculosis onset and the syringomyelia, if at all it progresses, it's going to be at least 2 years. The acute presentation of syrinx with the TB meningitis is very rare. So clinical presentation, the patient, usually if the patients have a syrinx and if the patient has a TB that is causing the syrinx, usually it's not the cervical syrinx, which is the common in other cases of hydrocephalus and other blastomas. It's usually the cervical syrinx. Whereas if it is a TB causing, then it's either a cervicothoracic or a thoracolumbar syrinx, which is the most common presentation. And syringomyelia developing as a case of acute complication. So there are only 2 case reports so far which had an acute syringomyelia after the diagnosis of tuberculosis. So 2 patients have developed that between 11 days and 6 weeks on the onset of tuberculous meningitis. So the described mechanisms are either an adhesive arachnoiditis that is at the skull base that is causing a hydrocephalus, that is causing a hydromelia. Second thing is a spinal cord arachnoiditis itself with the development of arachnoid or intramedullary cysts. So syrinx and TB. So there was one case report which had an acute paraplegia and intramedullary cavitation in a patient with a pulmonary tuberculosis, but this was a very, very old case. It was in 1992. So these are the outcomes for the medical as a surgical intervention. If you look at the outcomes, the better intervention in a patient who has had a syrinx with the TB is always the surgical intervention was very much better. But in our patient, after the initiation of ATT and steroids, within 10 days, within a span of 10 days, patient had a good improvement in the powers, also lower limb powers by the time of discharge with physiotherapy, and after the starting of ADT and DEXA were almost 3/5. So she also underwent a VP shunt because of the hydrocephalus. The thing is, she's under follow with us and the neurosurgery department. So if at all any worsening of the neurological deficits, if any further worsening, they plan to intervene for the syrinx. Otherwise, right now she's only on ATT and DEXA tapering dose. So the learning point is, one thing is, even though it's a TB meningitis, like if we have clinically like a dissociative sensory loss, we can still think of syrinx, because syrinx, although TB just causes a extramedullary extradural lesion, there are case reports and there can be a chance that there can be intramedullary involvement in TB also.
Can you go to examination? The next, CNS. Where would you anatomically localize your examination finding? Where would you anatomically localize?
One thing is, she's got a low bladder, and bladder involvement was there, and second thing, there was a paraparesis. So one thing is a spinal cord, it's a cord. Second, she's got multiple cranionopalsies, and
where in the cord did you get a level?
Should be actually at the level of L1, but the syrinx was at the level of cervicothoracic, like it was from C5 to T2. But if it was above L1, like that syrinx wouldn't explain the paraparesis. So what we thought was the paraparesis was probably secondary to the arachnoiditis, and the syrinx was causing the dissociative sensory loss.
What would you find in examination? Go to the previous one. If it is arachnoiditis.
If it is
in arachnoiditis,
there'll be with the tone, there will be hypertonic and it will be exaggerated reflexes.
Something is not fitting in the examination, no? You said bilateral knee jerk absent, ankle is 1+, with upper limb reflex present, with the dissociative sensory loss. What is the level for the spinothalamic localization?
For her, she had till C7 to T1, till her upper limbs. The thing is, we thought the jerk was absent because of the acute spinal shock. I'm not sure if why it was absent, because, but in acute spinal shock, it can be like that.
Ankle jack 1 plus, upper limb 2 plus. Probably a detailed sensory examination, and because things are not fitting, no, using acute symmetrical paraplegia. Acute symmetrical paraplegia with upper limb only sensory involvement, no reflex, no other track involved. Clinically, for you to localize to the spine, there should be more findings. I mean, everything usually should fit in. Plantars were down.
Extensors.
Bilateral extensor. Any
What's the level of sensory dissociation?
Till T1, sir.
From where to where?
From she was not able to feel from her deltoid itself, sir. So from C5 to T1, she was not able to.
That was corresponding.
Yes, sir. Yes. MRI was C5 to T2. They have mentioned, sir.
I was also asking that your findings and correlation. I mean, more important is for at your level is to see it very carefully and try to localize your lesions, justify your lesions based on what your findings are, because that's very important. Before you see what the MRI findings. So sometimes MRI findings may not correlate to the clinical findings. Sometimes you may have more findings than what the imaging is showing. So important that you can do those carefully and see whether it is what is fitting, what is not fitting. What is the mechanism of syringe in tuberculosis?
So one thing they're telling us, it's the hydrocephalus that's obstructing at the level of the CSF flow pathway, that itself will cause seepage into the intramedullary part, and it will cause a syrinx. Second thing is arachnoiditis that causes an intramedullary cyst here, that in the TB, in the spine.
Arachnoiditis causing
Development of arachnoid and intramedullary cyst by itself because of the inflammation, leakage of proteins causing a cavity, a cyst or a cavity in the intramedullary region.
The other mechanism that causes that is of and arthritis that can also cause necrosis, and that means cause seepage of disease. I mean, quite not a common thing. Very interesting case. Really appreciate it. I mean, I think the learning points over here is as impressive. This is a very good case for a good neurological examinations correlations. Apart from the whole concept whether TB can cause very interesting presentation of TB at all levels, and plus syrinx. You had a find. Did you all think about syrinx before the meeting?
No, sir. We were thinking it was arachnoiditis only, sir.
So that is so we learn kind of prospectively and retrospectively. Now that you have seen that, and then maybe you went back
and then checked again, sir.
It just tells us that on the whole, professors will only tell you one thing, that be strong on your bedside, and you should write that I was able to predict what imaging will show. And I mean, it should become a registration. It should become a reflex that you just go one by one, sensory at all levels, motor at all levels, reflexes, and keep thinking in your mind, how do I explain each of those things? That will really strengthen. And then if the MRI shows it, and that gives you that feeling that yes, I thought about it, that the imaging is also shown. So that's all about clinical learning. Of course, life is busy, everybody's in a rush doing few things here and there. Nothing like this rushing to clinical skills.
With this, we'll close. Any other questions? With this, we'll close our clinical meeting for today.